All right, so I am Jessie Burke. I'm Associate Dean for Education and Faculty in the Department of Behavioral and Community Health Sciences. And I want to welcome you all to our Pitt Public Health Conversations about COVID-19 seminar series. More information about the series and other COVID-19 efforts is available on our school webpage, where you'll also find recordings from prior COVID conversations. And responses to some of the questions that were asked but not answered during the sessions. So the format is that following my introductions, the speakers will discuss the topic, and then we'll open it up for questions from the audience. When we get to that portion, please use the Q&A function to ask your question, and we'll help to moderate the discussion. Please note that we're recording the seminar. So I'm excited today. It's a topic that I know less about, but I'm excited to learn about. Using the tools of statistics, biostatisticians help answer pressing research questions about public health. And biostatistical modeling, estimation, and decision-making support play an important role in the responses to COVID-19. It's my pleasure to introduce our guest speakers who will discuss statistical considerations involved in modeling the epidemic progression and in the use of COVID-19 related tests for estimation and decision-making support. Dr. Lu Tang is an assistant professor in the Department of Biostatistics at Pitt Public Health. He's broadly interested in statistical and machine learning applications for health sciences. He's currently involved in collaborative research on bedside decision-making, patient trajectory analysis, outcome prediction, and heterogeneous treatment effect estimation by combining modern machine learning techniques with traditional statistical inference. Since February of this year, Dr. Tang has been involved in epidemiological and statistical modeling for the COVID-19 trajectories. Our second speaker is Dr. Andre Bandos, who's also in the Department of Biostatistics, where he's an associate professor. His primary research interest is in the design and analysis of studies of the accuracy of classification and prediction. The major focus of his work is in the design and analysis of multi-reader retrospective as well as prospective studies of diagnostic technologies for medical imaging. Most of his work and methodological developments associated with it stem from collaborative work and really aim to address questions frequently arising in practice. So I'm now very pleased to turn it over to Dr. Bandos, who will begin our conversation today.
Hello, and let me try to share my screen. Just a second. Never works. All right, I think it should be all right now. So first of all, I would like to thank Dr. Berg for the nice introduction and for organizing this important webinar series. I would like to talk today about estimation and decision support from COVID-related tests. Oops. And again. My apologies. Oops. All right. Hopefully it will work right now. Sorry about that. Technology never works as supposed to. So testing is one of the most frequent topics in everyday news, and perhaps one of the most recognized test is the screening test for virus. And it's important to understand that screening test by itself does not solve the problem. It needs effective follow-up actions. Overall, there are many tests that help us in managing COVID-related challenges. And we can broadly group the testing goals into the decision support for decisions on individual levels, as well as an estimation that helps supporting decisions on the population level. And the common objectives of testing that we can think of is first, detection of ongoing disease, in which the virus test and a PCR test help us a lot, or are using the antibody tests for detecting positive.
Andre, sorry, I'm jumping in here, but I think you need to change the view for your PowerPoint slides. I'm just seeing the window.
All right.
Not the complete slide. And I know you have lots of great images on them that I want to be able to see.
So what do you see right now?
I see I see now just you.
All right.
But if you can share your screen again and put it in the presenter mode.
Do you see it right now?
Now this is perfect, yes.
All right, wonderful. So where did you lose me?
We did not get to see this slide. So if you want to start here, that would be great.
All right, wonderful. So, so again, I will start from the beginning. Again, the testing is the most important topic, and the screening test is what we probably all know about most. Again, it doesn't solve the problems on its own and needs effective follow-up actions. And we do have a lot of different tests that help us to make informative decisions on individual and population level. And the common objectives of testing are first, detection of ongoing disease, and second, detection of past disease, for which we can use the antibody testing. And imaging could also help us in classification of ongoing disease. All of those tests, they have a common problem, several common problems. First of all, none of them is perfect. And second, all of them are not that readily accessible. So one side of tests imperfection is existence of the testing errors. And there are two basic errors that we can think about. First is the false positive, which happens when we observe positive test result for condition-free individual, and the false negative corresponds to the case when we observe the negative result for condition-present individual. The importance of those errors really depends on what type of connected decisions and consequences we have. So if we think about virus screening, the positive test result could be associated with the quarantine decision. In that setting, the false negative would correspond to miss of active infection and therefore spread of infection, etc. False positive, on the other hand, would correspond to unnecessary quarantine with all the connected consequences. In this screening setting, you can see that the false negative is a much more severe type of error, but it's not always the case. If we think about the antibody testing, the false positive would correspond to erroneously suspecting past disease, which is arguably much more severe than the false negative in that setting. The important thing is that both decisions errors must be considered together and must be quantified in the target population. We have to consider both errors together because they can be easily exchanged by changing the positivity criteria. If we think about the trivial cases, trivial extreme cases, and test everyone as positive, we would have only false positive errors and no false negatives. On the other hand, if we do not test anyone as positive, if our positivity criteria is so strict, then we will have only false negative errors and no false positives. And it is important to quantify the frequency of the errors of the tests in the context of the target population where we will apply the test. And we need that for correctly interpreting what positive and negative means, as well as for correct estimation of prevalence and other goals. So conventionally, test errors are quantified with the false negative error rate or 1 minus sensitivity and false positive error rate or 1 minus specificity. Those two errors could be exchanged to help tailor testing for specific application. And that could be done either in non-informative way or by indiscriminately increasing the positivity criterion, or in some informative way, imposing the informative exchange of errors, which could be done with the help of quantitative test result or targeted retesting or other available information. And estimates of the test characteristics of the false negative error rate and false positive, they have to be assessed in the right context and with the right design and using appropriate methods. And that especially relates to the effect of having a representative sample from the target population. So an important illustration of these concepts can be seen in application to the virus test. PCR tests, when validated in independent studies, they are seen as very highly specific but not as sensitive tests with a false negative rate up to possibly 19%. That property of having no systematic false positive errors makes the positive test result much more straightforward to interpret. And in terms of false negative errors, there are many factors that affect that. And that's one of the reasons why we observe a large variability across different studies. If we think about the related decisions to the positive test result, the sensitivity of those decisions will be even smaller. And part of the reason for that is the number of untested individuals who cannot really be positive. So in that setting, one of the natural questions would be, is it possible to exchange some of the false negative errors for much less consequential false positives? And in fact, if we think about global distancing measures, they could be considered as such a non-informative exchange of decision errors. Indeed, if we quarantine everyone, all symptomatic, all test positive, and other non-diseased individuals, we do contain many more infections and asymptomatic infections. On the other hand, we pose costs of quarantining healthy people, job loss, and etc. And they're more beneficial, informative exchange of decision error is possible with tailored measures and also by increasing the availability of testing. So test availability can also be improved by specific testing techniques. And one of them is group or pooled testing. Though methods of group testing stem back to World War II, and the simplest approach can be seen as pooling case specimens together and testing each pool. If a pool comes out negative, we stop testing. If it comes out positive, we proceed to testing every individual in the pool, or maybe breaking down to smaller pools. That approach could save a lot of tests or can make tests available to many more people, for twice as many people for low prevalences. On the other hand, that approach could lose all the advantages if improperly designed. And to properly design the pooled testing, we do need to know test characteristics, pooling consequences, and characteristics of the population. So another remedy for the improved test availability and increased sensitivity is provided by imaging tests. Imaging tests, they rely on radiologist interpretation, and because of that, they are naturally variable. They're also often non-specific. On the other hand, they are quantitative, which allows for some error exchange and tailoring the test for specific purposes. To help with the variability due to radiologist interpretation, There is an active area of research of developing computed imaging markers, which could help improve accuracy of radiology decisions. And that's a special area that aims for the targeted improvement. Often there are many interesting nuances there. One of them is that the most helpful marker is usually not the most accurate overall. And there are additional complications. One of them is the necessity to assess errors of the imaging tests, both in the context of the population of cases as well as in the context of population of radiologists. Another testing that we often hear about is antibody testing. And that testing becomes, that becomes useful usually later in the course of disease. And it's used mostly for detecting post-infections. Among the available tests, there are some that are quite accurate, although still imperfect. And there are many other rapid tests that tend to be less accurate, but still quantitative, which allows some informative error exchange. One of the big problems with antibody testing is the implication of the results, because a positive result, even if true positive, does not immediately indicate protection from infection or non-infectiousness of the individual. So another application of testing is the support of decision making on population level via prevalence estimation. And in prevalence estimation, we again need to account for the test errors, because even largely accurate tests, the number of test positives could be substantially higher than the actual prevalence. And in that application, pooled or group testing also provides tremendous help. Not only does it help in terms of the number of available tests, but it also somewhat counterintuitively helps to produce more precise estimates of prevalence. And again, efficient application of group testing requires knowledge of test characteristic as well as pooling consequences and using the appropriate analytical methods. And there are a lot of different methods that are developed to improve efficiency of that approach. So overall, there are many tests that are available, and new tests are constantly being developed. It's important to remember that testing is a powerful tool, but it is not perfect, and it does not solve the problems on its own. Testing is essential for lowering costs and losses during epidemic mitigation, but it needs to be paired with effective decisions, contact tracing, targeted quarantine, or with other tools such as models of epidemic progression. And it is critical for efficient application of testing. It's critical to understand and assess test errors in the target population, because not only they help us to interpret correctly the test results, they also allow us to tailor testing for specific application, reduce errors for specific purpose, as well as to increase availability and help with estimation. Overall, we are constantly learning more and more about the disease and the property of testing tools, and this will certainly help us better address future challenges. With that focus on the future challenges, I will pass the screen to my colleague, Lu Tan, who will discuss the modeling of epidemic progression. Thank you all very much.
All right, thank you, Andre. Thank you, Jesse, and your team for the introduction and for hosting this wonderful series. And following Andrew's presentation on the testing, I am going to talk about the modeling and prediction of COVID-19 progressions, which is largely depends on the data generated from the tests. So let me move on. So in the past couple of months, there has been a surge of research papers published in journals or on archives, and an economist in a tweet described that the trend of research on COVID-19, it could be kind of described as growing even faster than the disease itself. So here's another one. A researcher even tried to use infectious disease models to estimate the growth rate of research papers, although somewhat jokingly, of course. So of all of these different type of research related to COVID-19 or SARS-CoV-2, I personally, as a biostatistician, have been following the statistical and epidemiological modeling and their developments, and also have been very lucky to participate in the modeling with a group of biostatisticians since right after the Wuhan outbreak. So just a disclaimer here, not an epidemiologist or an infectious disease expert. So I'm purely coming from a perspective of statisticians. So what we have witnessed in the past couple months is actually a great sense of uncertainty, especially regarding to the forecast. And the social media has been flooded by different statistics and forecast models, and as described as an epidemic itself. And also because of this different uncertainties and conflicting results, it further creates a sense of uncertainty, as this picture from New York Times very nicely captures the situation here. So the question of where things are going has still not been solved. So even the same group of researchers that we see couldn't keep their prediction consistent from time to time, and they have to change over time, which caused a lot of confusion. So that brings up to my the key point that I hope to discuss or bring up for discussion is that about how do we interpret or convey the uncertainties, specifically regarding to prediction or forecast. So here's an example. This is one of the most popular, one of the best known model for creating projections of the current infectious disease pandemic. And it is created by a group from the Imperial College London. It started to gain public attention in mid-March. And although it predicted it predicted 500,000 deaths in UK and 2 million deaths in US in the absence of any mitigation effort. Which is one of the main reasons that prompt the government to take rapid actions. So in the figures specifically, this is the number of predicted number of deaths per day in the New York State. Well, from the top to bottom, respectively, is using data from 14 days before the peak, 7 days before the peak, and using data up until the peak. And you can see that with different level of data availability, with more and more data we have, then actually going forward, the prediction captured by the yellow line and the gray area captured by, which is capturing the uncertainty, often known as the confidence interval or credible interval, is becoming smaller and smaller. So there is a large amount of uncertainty at the start. So the model that they use, if you're familiar with statistical concepts, they use a Bayesian framework, which allows you to incorporate prior knowledge into the models. Especially this is very useful when at the early stage when we don't know anything or don't know too much about the disease itself. So this is a similar flavor as the model that we also use. So another example I'm presenting here in this slide is another model that was developed by the Institute of Health and Metrics from the University of Washington. And this model started getting attention in late March. And although you can see that on the right-hand side, the smaller panels shows the underestimation, a clear underestimation of the uncertainties, since the prediction captured by the blue curve goes quite outside of the range rather quickly. So this model is actually, the earlier versions of this model is actually pretty vigorously criticized by epidemiologists because it is not based on the transmission dynamics of infectious disease, although eventually they did switch to a more mechanistic model that accounts for that. So despite that, it remains one of the most highly cited group, and it was also mentioned in their White House briefing. So the point is, I want to compare and contrast and just make a point that this uncertainty is really important and we should not underestimate or should not ignore that. So here are some sources of uncertainty that could potentially result in why we have seen such level of uncertainty in the future, especially regarding to prediction. So first of all is related to the data. Especially what we observe is not representative of what the actual data we want to estimate. So for example, the number of cases that are reported is highly dependent on the testing regimes. As an example, early in April, Germany has done more than a million tests compared to UK, which is pretty much a lot less. So you can see that this creates that the number reported is going to be much higher in Germany, but the reality might not be true, that the actual infected case might not be reflective of the reported ones. And also the death only captures those who died in hospital and those given that they have tested positive. And usually there might be a delay in reporting. Additionally, as Andrew already mentioned, that there is accuracy regarding the test to the test that has been used, which is governs the data that will be further used for modeling. And the second big item is about the modeling and the mechanisms, which is related to the understanding of the disease itself. And if we don't have a good understanding of disease, we were not able to account for some of the mechanisms. For example, in the early stage, we don't know that there could be asymptomatic cases that in this infection. And also we are not sure about the incubation period. And also it is really hard to measure the mitigation efforts and what that actually represents and transfer into the modeling and the consideration of the modeling itself. So last bullet item is kind of a very broad category. It says that there are individual level heterogeneity, region level heterogeneity that all needs to be taken into account. And all of these contributes to the uncertainty in the modeling of COVID-19. So one of the things, as this sounds distressing, but if we can turn this into an advantage, and here are important things to do is to acknowledge such uncertainty as people who are on the receiving end of informations. We cannot just look at the predictions, but also acknowledge there is uncertainty. And also for practice and decision making, it is better to focus on the shorter projection and to focus on the worst case and prepare for the worst case and scenario in the long term. So put that in the perspective of what it means locally. Here's a model, a very simple demonstration of the modelings by accounting for a time-varying mitigation efforts. So there are different levels of social distancing measures that has taken place over time. And for example, let's assume that before the stay-at-home order, there was 0% of reduction in transmission, right? So that's 100%. And then after the stay-at-home order, it brings down the transmission to, let's say, 50%. And after the universal masking, then it further brings it down to 20, but the reopening is going to make this transmission go back up to 50%. So in this figure, so in the bottom figure, the left one is the predicted cumulative infection incidence, and on the right-hand side is basically the difference, so the daily increase. And this is a demonstration using data up until May 31st, and the prediction is beyond that time. So you can see that this is the confidence region estimated, and it's pretty wide because of all the potential uncertainties due to the data measurement error and the modeling errors. And on the right-hand side is the daily count, daily increase. And here simulated 20 different trajectories, and these trajectories varies quite a lot. And to give you some perspective, the peak here, the peak on the screen here is around 60 new cases per day. So as we open up, there's potential that if we don't control the reproduction number effectively, there could be still a rebound. So That brings back to the point of uncertainty, and in order to mitigate uncertainty and account for that, here are two key points. One is to, when we make decisions, account for and look for the platforms that could aggregate or combine multiple prediction models. And CDC and other labs have been doing that. And also to include the proxies for the unknowns, to actively counter the unknowns by using historical experiences and mobility data to account for the transmission and people movement and economic data, and also the knowledge about closure, and more importantly right now at this time is about the knowledge of reopening to account for the unknowns. Also, Dr. Donald Burke mentioned about the seasonality. So as we go into the long term, this will be a pretty important factor to account for. So with that, I am going to wrap and turn it back to the discussion.
Lou, thank you so much for a very nice talk. Thank you. It was very interesting. Quick question. So there is a lot of uncertainty in the predictions. What is the time span for reliable projection by the current models, given there is no change in mitigation efforts?
Thanks, Andrew. Thanks for the question and kicking things off with your presentation. And regarding to a question for the time span, I think that the most challenging thing is that we are not able to accurately predict the mitigation strategies in the long term. So presume that if there is no possible change in the mitigation effort, then most of the models are quite reliable. Consider that we have account for all of the other kind of uncertainties. Those are the uncertainties that are easy to quantify, but the most impact to the shape of the curve, as we all say, the flattening the curve, the most impact to the curve is usually due to a different kind of mitigation efforts. So those include social distancing and the self-quarantine and the centralized or mandatory quarantine, like the ones that have been implemented in China. So those are very different in regions. So there are so that is the case regarding to the long term, and that it is really hard unless we have a very good knowledge about the strategies of the government. So on the other hand, we always have more uncertainty at the beginning when we have less data, but as we accumulate more and more data, then this uncertainty should be reduced, and we are a bit more sure about this future. So regarding that, actually, there's one thing that I would like to bring up for discussion is about this uncertainty also related to the testings, and how are these uncertainties currently, like for example, the sensitivity and the specificity, or false positive, false negative, how are they conveyed to a user from an individual perspective, especially like, is this the current testings, do they borrow the same strategy as the other medical tests that has been used out there?
Right. That's a really good question. That's a really good question, and usually there are no open numbers about sensitivity, specificity of false positive and false negative errors, but there are guidelines, and often guidelines try to use word expressions, and they indicate that if the test result is positive, you're most likely to have the ongoing disease, or if your test for antibody is positive, it's likely that you had disease in the past. Those most likely and likely sometimes used to indicate the relative accuracy of different tests. On the other hand, I think it's not often, sometimes it is done, but it's not often, not always done, that the relative importance of errors or relative frequency of errors are conveyed. For example, in terms of testing virus with the PCR tests, the false positives, they are almost non-existent. So that makes positive test result much more reliable than the negative. So it would probably be fair to say that if you're tested positive, you most likely have the ongoing disease. but if you tested negative, you maybe do not have the disease, because again, it all depends on the amount of error that we have. And if the error is indeed around 20%, that's a pretty large error for the negative test result.
So a follow-up question about that is that I wonder if these type of errors will, if we use the same kind of test for group testings, will these errors propagate, like potentially the group testings at each level is going to also be using these similar type of tests with the pool samples, right? So is that going to affect the group testing results in general?
Yes. So the group testing strategies, they do rely on first the accuracy of the test when you apply it on individual level. There are also some consequences of pooling data, pooling specimens together. Sometimes it depends on how many you pool together. Conservatively, in 2 to 5 specimens pooled together usually did not pose many problems, but there is a possibility that there is a differential sensitivity with pooling, so that needs to be also investigated and addressed. So there are no perfect solutions. It's a very good tool, but it does require careful implementation and assessment. And the errors, they do propagate in pool testing as well.
I see.
So this is Jessie. I'm going to jump in just because there are a number of questions that are popping up that are sort of follow-ups to some of what you've been saying. So I think, Andre, to follow up, there's a question about the false positive, false negative determination requires a gold standard for defining the presence of a disease. And what are the gold standards for COVID-19 viral detection and for COVID-19 antibody testing? If you could talk a little bit about that.
Right. Yes, that's a really good question. Yes, indeed, all the assessments of the diagnostic test, screening test, they do require presence of a gold standard, and it's not always easy to come up with one. For virus testing, usually the serial testing approach is implemented if a person has been tested positive on one of the several tests that were performed in a series spread up apart, let's say for 8 to 24 hours, that would be considered positive. There are also possible positive cases which are considered determined based on clinical symptoms, on imaging, etc. So for every case, and I guess, I mean, with the time, the definition of what is the gold standard might change a little bit. There are, as we have more and more tests, it will be more easier to do, and eventually we will end up with something as a gold standard. Again, in the laboratory testing, one of the approaches was to use specimens from a pre-COVID-19 era, when we know that it was not circulated, and that was also used as a control group for the antibody testing.
Great, thank you. So can I then also follow up with a question for you, Lou? So to follow up on some of the modeling. So a question is about the sources of data on the mitigation strategies. So what's the most common sources of data? Is it from other populations? Is it best estimates? Are there validation studies underway right now? And then when you're done answering that one, I've got another one for you. But so if you could start there, the question specifically about sources of data on mitigation strategies.
Sure, sounds good. Thanks, Jessie, for the question. That's a really nice question, and I could take it first, and maybe Andrew can add on to it, since the data that we have, and so especially regarding to mitigation, then it is mostly based on the public common knowledge from the news. So this is really what we have done so far, but there are other things that I could think of could be incorporated. That includes like these are might not be the public data, but like companies that will be able to have track mobility data, like not on an individual basis, but on more like a traffic flow, or how many captures the people's movement in general, and also captures the business opening and closing. So for example, Google will have this type of data to better describe how effective are the mitigation strategies. And usually these mitigation strategies, especially regarding to COVID-19, some of them changes pretty rapidly. So if there is one order that was being sent, then people would follow immediately, and then that should be reflective by the data. And that sort of serves as a validation to see if these data better is good enough to capture these type of change in the strategies or mitigation strategy levels that is implemented.
Yes, and to add to that, I mean, it's indeed it's difficult to capture all mitigation efforts at any given point in time, and one of them is the availability of tests and how many tests we have available on every given day. Definitely, if we have more tests available, we could observe more cases. So there is, because of that, we have a fluctuation in the number of cases. And the health department website, they're usually quite good in terms of trying to at least indicate of how many cases were there positive, or how many were negative, how many were probable. It still might not be that easy to come up with how many tests were given on any given date, but again, it depends on the sources that you try to find. But yes, indeed, it's one of the challenges with estimation and modeling.
And so a follow-up to that is, are the prediction models taking into account the variability of the number of COVID tests that are conducted each day?
Good question.
That is a good question. Maybe it's a question for both of us. So I think the number of testings, the data that we use is actually you can see that if there is the testing certainly affects the data being reported. And one big interesting phenomenon we see is the change in the criteria of testings. So I know that this is for the data is specifically for Wuhan is in the early February. On February 12th, there is a very huge spike in the number of reported infection cases on that single day. And that is reported to be due to the change in the criteria to define positive. So that is potentially related to the arrow trade-off exchange of arrows related to these testings. And also there are human delays, or potentially there are burdening the hospitals have a lot of burden, especially in the beginning, and that there could be further resulting in the delays in these data. So those are the points that could leads to the data that multiple different type of criteria could be considered sort of as a variability of from a different type of test. So that has to be accounted for, and two strategies. Maybe one is using smoothing to smooth out the data, assuming that these new cases, they actually attribute to earlier days based on these belief that these are data or incidences from earlier times. And another is to do kind of model calibrations.
Yep, I think that the fact of availability of number of tests available and how you count that for the correct estimation, that's combined with the test accuracy, it's important point. And yeah, it's important really to take into account into the modeling. On the other hand, as Lou mentioned, modeling could smooth and make some adjustments within the model without pre-processing.
Great, thank you. So now a more specific question, if you could speak to some of the numbers in the guidelines and the mitigation strategies. So for example, how might a gathering of 250 people been decided upon as opposed to 300 or 200? And I don't know if that's, it's a tiny bit outside of what we've been talking about, but certainly relevant. If you can speak to maybe how some of that is being handled in the modeling side, some of the, essentially the mitigation strategies that are explored within them.
Yep. Yeah, I think it's more question to Lou. I mean, from how I see that the number of people who call out to gather recommended not to gather more than that is determined based on the several factors. One of them is estimated prevalence of infection, and as well as the other composition of population, including the susceptible individuals and as well as the reproductive number. But I think Lou will be able to answer that better.
Lou?
So that is a very challenging question. Regarding to that, how many number should we decide? It's really hard to tell because I don't know the answer. So the number is probably, if you treat this another way of thinking is we could treat this type of gatherings as some type of potential local events, like by treating it as spatially local events that accounts for the spatial heterogeneity that you could potentially try to actively counter or model these things into the model. One of the, so to give it a very general example, so in order to account for these spatial heterogeneities, one way is to develop separate models for separate regions or separate by accounting for different population densities. And let's say if we model the US data, we could consider looking at county-specific, state-specific data trajectories and also accounting for the people's movement and migration between these regions. So in that sense, you try to actively account for the heterogeneity. Then, of course, in New York, there is much more denser population than in another city or another state. So then, by treating it as like a different different level of transmission possibilities, then we could have better models and more accurate models to inform these type of decision makings. And well, the bottom line I feel like is that as long as we have enough data, more data, the finer data, we should always make use of that. So transferring back to the question, then we could also try to consider these small gathering events as like as expected events to be happening, and how that potentially would how that heterogeneous events compared to the general development progression of the disease, and how they would impact the general development of the disease, assuming that we don't have those events. So that would hopefully be able to inform and get some information about what is the impact of these type of gatherings.
It's a difficult question to answer. I appreciate your response. I think we all have many questions about, you know, some of the guidance that is coming out and where that guidance is coming from, especially given some of the uncertainties that we just talked about in terms of the modeling and the testing. And so I'm going to ask you a question about sort of how do you convey the uncertainty of the models, or what recommendations do you have about conveying the uncertainty to the general public, right? I think you both did a nice job of talking about this within the testing and within the modeling, but how do we ensure that what you've shared with us today, that we can communicate more broadly, given that we're all in the middle of this pandemic? Maybe we could start with you, Lou.
Sure, sounds good. in terms of how do we mention this, so first we want to definitely acknowledge that. So as so there's so this especially as the speakers from last week's seminar series mentioned, that there is a lot of disinformation in the tweets and other social media platforms, and it is especially important to try to convey as much information as possible, and acknowledging that there is uncertainty if we are able to do so. So that includes maybe avoiding using of these difficult terminologies that needs to be defined so that the audience would be easily accept. It will be easier to accept the information and the message. And also convey uncertainty also includes trying to talk about maybe the best or the worst case scenarios instead of just talking about the most probable scenario, because it could change, right? So, and also I feel like personally it would be more helpful to, because our models are based on, are for the populations, and people usually want to know what's the implication for them as an individual. So it would be helpful, especially to translate the modeling results for the entire populations to like a personal perspective. I think this will be something especially helpful, especially for the testings, what it means by the testings for each individuals. And well, nevertheless, we should always rely on experts and helping us communicate all of these type of findings and results.
So yeah, to add to that, I mean, in terms of testing, it is important to convey the fact that test results, they do not automatically mean underlying condition. So yes, if you're tested positive for the virus, you have ongoing disease. If you're tested negative, that really might not imply that you don't have a disease. And to a certain extent, that is already conveyed in some of the explanations or guidance. And one of the examples is their guidance on the return to work for previous infected people. It says that you don't. It's not one test that you actually need to obtain to observe a negative result. It's at least 2 tests spread apart like 24 hours, and that's one of the examples of exchanging the false negative towards false positive error, because by being negative on both test results, you increase your sensitivity to detect ongoing disease, and therefore they are more certain in negative test result. So definitely there is something. I mean, there are more education and conveying of information that can be done to help interpreting the test for individual decision making.
That's great, thank you. So we're running out of time, but I've got a couple more questions. So one is for you, Andre, about the error rate for testing right now for COVID-19, and whether or not the US has adopted the group or pooled testing procedure. If you could just say a little bit more about that, the pooled approach too.
Right. So in terms of individual tests, we know that the virus tests, they do not produce any systematic false positive errors. So the errors are mostly limited to false negative, to lack of sensitivity. And that is a variable number. It depends on the test that is you actually using. So some of them are a little bit better, some of them are worse. Another problem is that it really depends when the test is conducted, because sensitivity of the test varies in time from the disease onset. And in terms of pooled testing, group testing, there are certain labs that use that in Nebraska. There is also a recommendation by CDC, I think, that you can actually use the pooled test, and they adopt a little bit conservative approach and saying that you can do that in samples of two, so you can pull 2 specimens, and that's better than nothing. That helps to increase availability of tests. So, but yes, definitely there is more should be done or could be done to improve accessibility or availability of group testing techniques. But there is a lot of there are a lot of caveats, small caveats in implementing the pool techniques. So it needs to be carefully researched and slowly rolled over rather than just jumped into it.
Great, thank you. So I think we are running out of time. I want to give you each a minute or less, but to any concluding remarks or comments that you want to share with us before I wrap up. I really appreciate you taking the time to talk to us about the role of biostatistics within the COVID pandemic. I think it's important for us to think about it. Also what role you all play in public health more generally. So I appreciate you taking the time to explain these issues here today in terms of testing and data and the need for more data so that we can increase the certainty of the modeling and the forecasting. Any comments, closing comments? We'll start with you, Dr. Tang.
All right, thanks, Jesse. So in terms, I think that in terms of modeling, there are still a lot of things to be done and a lot of things that we don't know. And I would say that even if this is there is a lot of uncertainties, then we should not be kind of bogged down by pursuing such potentials to counter or actively discover these things, because as we get more and more data and we have better knowledge about these the disease itself, it should be able to give us better modelings. And beyond modelings, I think that as a individual person, so that we also need to know what it means to ourselves and to our own, that what does that mean, the level of uncertainties of where these things are going. And it would really be helpful to know, the more we know, actually, then the less fear we will have, especially regarding to the uncertainties of the COVID-19 disease.
Great, thank you. And Dr. Bantos.
Yes, I think I want to wrap up on the statement that we need to remember that testing, although it's imperfect tool, it is critical and very useful. We just need to know how to use it. And the important component of knowing how to use the test is to know the possible errors in the population to which we would like the test to apply. And it's not something that we know immediately right away, especially nowadays, because many of the tests, they were not approved, but they were granted authorization for use under the emergency authorization, which does not imply rigorous testing, as rigorous as usual. So hopefully going forward, we will know more about testing, about disease, and be more prepared for future challenges.
Great. Well, again, thank you both so much for taking the time today and for our audience for their questions. I want to thank everyone for the conversation. I learned a lot, so I appreciate that. I also want to invite you to join us again next Friday when we'll hear from Wendy Braun and Catherine Haggerty, and they'll lead a discussion about the health department response to COVID-19. Both from the local level and then the state level. And then to remind you that recordings of these conversations are available on our school webpage, and any questions that we didn't get to today, and there were a couple, I'll ask the speakers to answer those in writing, and we'll post the answers on the website as well. So again, thank you all so much. Have a wonderful evening, and I will see you back here hopefully next Friday. Take care.
Thank you very much.